Welcome to Menopause Rescue. I'm Dr. Polly Watson. Midlife women are often caught up in a sea of symptoms. Too often, they're overwhelmed by the lack of support from mainstream healthcare. They're inundated with so-called experts who are selling solutions which may lack credibility. I'm a Menopause Society certified gynecologist with both traditional and functional medicine training. I'm here to guide you through this transition and help you decipher the facts from the fads. Armed with credible information, I hope you are empowered to rescue and restore your health, making the second half of your life your best. Hi, I'm Dr. Polly Watson, your host on Menopause Rescue. Today, we're going to be talking about starting hormones over the age of 60. And this is a question we get a ton of people calling into the office. Hey, I'm this age. Would you consider starting hormones for me? And so I kind of wanted to dive into why would we consider this? Why institutionally doctors have been trained to be afraid of this and what the data really shows. And so I hope this will really help people have kind of a roadmap about how we would individualize making that decision for women who are interested in starting hormones over the age of 60. I'm really excited about talking about this. I think this is an important topic for so many women. Unfortunately, yet again, the WHI is coming back to bite us in the backside, right? And so a lot of the fear and the concerns have been based on hormone therapies, conjugated equine estrogen or Premarin, and medroxyprogesterone acetate. So when that's combined with CEE, it's called Prempro. We don't really use these formulations anymore, but all of this fear and all of this concern has been generated based on hormones we don't use anymore. And now we're applying those risks to current hormone formulations for which they're probably not relevant. So let's just dive right on in. So hopefully we can untangle this mess and again, give you a roadmap if you're over 60 to think about what is an intelligent framework to reconsider this decision making. And I just kind of want to hold space for women for a moment because so many women have been affected by undertrained healthcare providers who didn't get and didn't seek out to complete their education, menopause literate training, right? And so even in OBGYN residencies, right, we're the vagina doctors, we're supposed to know everything there is about women and reproduction and hormones. Very few residency programs when I trained 25 years ago, and even now, only 30-ish% of residency programs have a formal menopause curriculum. That's unacceptable, right? So the medical establishment has failed to train healthcare providers in menopausal medicine. So a lot of women are getting bad information. And now that we're finally overturning the WHI 20 plus years later, a lot of these women literally missed the boat, right? So we know that starting hormones around the time of menopause transition is going to provide the greatest benefit for cardiovascular health, bone health, brain health. We know that. I would argue, and we've talked about this in another episode, of staying on hormones, right? We don't have a time clock. If you initiate hormones around the time of menopause transition, I would argue, particularly if you are using transdermals and oral micronized progesterone, there's no reason to go off. That's not what today's about. Today, we're talking about starting when you missed that magic window. And here you are, and we're trying to figure out if this makes sense for you. So let's dive right in. Why would you consider just starting hormones after the age of 60? And I would say I would kind of group them in about 5 or 6 areas. First one is really low-hanging fruit. You're still symptomatic. You're still having hot flashes and night sweats. You're still, those are things we call vasomotor symptoms. That would be a really good reason to consider it. The second reason might be you want to protect your bones. The third reason is maybe you're having sleep disruption. We do have data to support hormone replacement therapy supporting sleep. A lot of us are waking up to the fact that we need to build muscle for longevity, right? So if you're a midlife woman over 60 and you're picking up those weights and you're going to the gym, You could be experiencing musculoskeletal syndrome of menopause. You could be having muscle pain. You could be having joint fibrosis. You could be having tendonitis. Estrogen can help that, right? So if we're going to say, hey, you've got to protect your bones, go to the gym, are we not educating you about the role of estrogen in maintaining healthy muscles and muscle repair? So I would argue, the reasons to consider would be you're still symptomatic. You want to protect your bones, sleep. We kind of put in the same bucket with that: mood, musculoskeletal syndrome, and menopause. We're still learning about brain effects. I know we have the most convincing evidence that estrogen is good for the brain when we start it before onset of menopause, meaning before we've had our final menstrual period. But I still think there's room to consider protective benefit on the brain. I think we're just still learning here. So let's start going through these one by one. What about symptoms? How many women are still symptomatic over the age of 60? A lot. So if we looked at the study of women's aging across the nation, that study found that hot flashes and night sweats persisted in 42% of women between the ages of 60 and 65. So almost half of women are still symptomatic at that age group. And if we look at women who are in their 70s, 10 to 15% of them still have vasomotor symptoms. So this is a lot of women that are potentially still symptomatic. If we dive into that study a little bit deeper, we really want to point out the fact that African American women are the most symptomatic, and they're symptomatic for the longest amount of time. So on average, African American women are having symptoms for over 14 years. So again, just reframing this, telling women that they just need to continue to suffer for over a decade of their lives is absolutely unacceptable. We would never tell men this, right? So being symptomatic might be a really obvious reason, and there are a lot of women that are still symptomatic over the age of 60. What about bone health? We know that the risk of minimal trauma fracture. So minimal trauma fracture is not, I went skiing, fell halfway down the mountain and landed crazy on my leg. That's not it. Minimal trauma fracture is I stepped off the curb and broke my hip. There wasn't an amount of trauma that should have caused a bone break. It was that the bones are so fragile that they broke with sort of activities of daily living. So minimal trauma fracture increases with age, and women who are above 50, that risk goes up all the time as we age, such that 1 in 2 postmenopausal women will have an osteoporotic fracture in their lifetime. Okay, let that sink in for a minute, right? When we go further in this podcast and we're talking about like 23 women out of 10,000 have an increased risk of stroke, and we're thinking about risk versus benefits. If we're trying to prevent fractures, 1 in 2 women are going to have a postmenopausal fracture. So we want to reframe this conversation into looking at the whole woman, right? And so if estradiol is FDA approved for osteoporosis prevention, it might be worth considering thinking more carefully about not allowing women to have that protection. Now, I tell patients this all the time. The best time to protect your bones is around the time of menopause transition. So even in perimenopause, the rate of bone loss is much more steep or significant than if we're 65, right? But we're still losing bone at 65, and we could still offer some prevention if a patient, quote unquote, kind of missed the boat earlier in their lives. And there are a lot of women who were not offered hormones at the appropriate time. So the solution is not to just say, sucks to be you, sorry. It's to really dive into this and try to get clarity on what those risks and benefits actually are so we can personalize care. And as an aside, I know I said that I wasn't going to talk about stopping hormones after the age of 60, but I am for a minute, because this is one thing that makes me crazy. A lot of women come in my office and they were on hormone replacement therapy. They were started appropriately around the time of menopause transition. They hit their 60th birthday, and their healthcare team acts like the carriage is turning into a pumpkin. This is an emergency and they need to go off their hormones. If we're thinking about their bone health, withdrawal of hormones is followed by significant bone loss, such that after you've been off hormone replacement therapy for about 4 years, your bones look like you never took it. Okay, I have a reference for this. So all of the articles I'm going to be referencing in this talk, I've made a Google document. So if you want to go behind me and check me, feel free. I've got a list and we'll attach those to the show notes. So estrogen can be very protective for the bones. It only works while we're taking it. Okay. And I think when we're thinking about bone health, another thing to consider is that bisphosphonates, which are the sort of first line drug recommended for osteoporosis, aren't well absorbed. They're often not well tolerated. They have a lot of side effects. And so, again, trying to get prevention in place, treating the musculoskeletal syndrome of menopause, getting women into the gym, having them lift heavy under supervision, adding estrogen when appropriate can really help slow down bone loss, which, again, if we're thinking about the whole woman, 1 in 2 women is going to have an osteoporotic fracture. So I think this is a really important area where we probably need to rethink the big red light that pops up for women when they hit their 60th birthday on either stopping hormones or it's a roadblock to starting hormones. What about sleep? And I think this is so important as we're learning more and more about neurocognitive decline and are working to prevent neurocognitive decline. Because if you don't sleep, nothing works, right? Your brain's not working as well. You're not recovering as well. Your immune system isn't healing. Nothing is working, right? And we have studies that show that transdermal estradiol, a more modern, less risky approach to taking hormones with oral micronized progesterone, improves sleep quality. And we've seen this in a meta-analysis, so a study of a group of studies of 15 different studies. And I'm including the reference for this. This is from Menopause from 2022. So sleep could be a real reason why we might want to rethink starting hormones in a woman over the age of 60. Again, thinking about the whole person, thinking about neurocognitive health, what else is in our toolbox here, right? Hypnotics, medicines like Ambien, even medicines like Benadryl, used long term, have been shown to cause neurocognitive decline. They're increasing our risk for dementia, right? So transdermal estradiol and oral micronized progesterone are not increasing that risk. So if we can help someone sleep and avoid using a drug that has no negative benefits, why are we not doing that? So we've talked a little bit about why would we want to start using hormones. We talked about symptoms. We talked about bone protection. We talked about sleep. We talked a little bit about the consequences of using a lot of sleep medicines, which is negative on neurocognitive effects. We've talked about musculoskeletal syndrome of menopause. Those are to be all reasons why we would consider taking hormones. And now let's kind of dive into why women have been discouraged by the medical field by using hormones after the age of 60. I just want to kind of go through this step by step because I think there are a lot of things, and it's astonishing to me as a physician how entrenched this is for discouraging physicians and clinicians to prescribe hormones. So maybe we'll just start with that. When I'm in my office and I'm in my electronic health record and I don't write a lot of controlled substances, but let's say I'm writing for a benzodiazepine, which we know is habit forming and can destroy people's lives, like Valium, right? Occasionally I'll write for vaginal Valium for a patient who has significant pelvic pain. And so I'm using a controlled substance. No alarm bells go off when I'm writing that prescription, right? Even though we know that's a habit forming substance and can cause long-term harm. When I put in a prescription for hormone replacement therapy, modern versions for women over 60, immediately a window pops up and it says, "You're about to prescribe a high-risk medication. Do you want to do that?" And I have to hit, "I am declining your warning," to proceed to even fill the prescription. Then, once I write the prescription, I get a snarky letter back from the insurance company that says, "Hey, you wrote a hormone replacement therapy prescription for someone over 60. The 2022 guidelines from North American Menopause Society says that benefits outweigh risk for women under the age of 60. Okay. And then they're implying that risk outweigh benefits over the age of 60, which is not what that document says. And so as a patient, you've gotten a lot of pushback by your clinician. Let's have compassion and know that they didn't get the training they deserved. And also they're getting like a whole lot of negativity every time they do that. So they've got to have confidence and a little chutzpah and know that they're doing the right thing, even though there's system-wide discouragement to prescribing hormones in women over 60, which is not evidence-based. So your doctors have been taught to be afraid and undertrained. Why else? Where is this risk coming from? What are we talking about? And a lot of the risk is coming up with blood clotting risk. Okay, so venous thromboembolism is a blood clot in a vein. Typically that's in your lower extremity. If that breaks off and the clot goes to your brain, that's a stroke. If the clot breaks off and goes to your heart, that's a heart attack. So I'm kind of lumping blood clotting risk altogether. Now, a couple things to keep in mind. Women who are on hormones, who are on hormones, age increases our risk for blood clotting. Okay. So that's a known increase just for being a human on the planet who's gone around the earth that many more times. Okay. One of the big differences that we cannot emphasize enough is that the Women's Health Initiative study was done on conjugated equine estrogen, which was oral estrogen. Okay. So where did all this fear about blood clotting risk come from? In the WHI, we did not study transdermal estradiol and oral micronized progesterone. Those are modern formulations of hormone replacement therapy, or what we call PET therapy, progesterone, estrogen, testosterone therapy, that most people currently use, and I would argue is the standard of care. Okay. So all of the claims that are made on hormone replacement therapy risk that came from the WHI are on completely different drugs. So a progestogen versus progesterone, conjugated equine estrogen, which is pregnant horse pee urine estrogen. You are not a horse, right? Versus transdermal bioidentical estradiol, a chemical copy that your body already makes. Okay. When we're looking at risk, a lot of the studies, the predominant hormone study that's been done in the United States, the WHI, and all the subsequent reanalysis of that was not done on hormones we currently take today. So let's take a look at the differences. What do we know about modern formulations? Okay. There's a paper from 2010 in Climacteric by Dr. Spiroff looking at transdermal hormone therapy and the risk of stroke and venous thrombus. In that paper, he found that women who were on transdermal estrogens with or without a progestogen or progesterone did not have an increase in stroke or a blood clotting event. And he found that that was true up to a dose of 50 micrograms. So if you're thinking about an estradiol patch, that's a 0.05 patch. Okay, kind of middle of the road dose of the patch. And this was a pretty good observational study. They had a large number of cases, over 15,000 cases, and almost 60,000 controls. So this was a pretty well done study. Then, so that was 2010. In 2018, we have a meta-analysis, a study of studies that looked at systemic reviews and found that overall, transdermal estradiol doesn't increase blood clotting risk. So in this study, they found that in transdermal estradiol users, there was no change in venous thromboembolism risk in women using micronized progesterone, whereas non-pregnane derivatives, so different types of synthetic progestogens, did increase VTE risk, right? So when we're thinking about clotting risk, the way we deliver estrogen and the type of estrogen matters. And the type of progesterone versus a progestogen also matters. Okay. So that's why a lot of people are moving forward talking not about HRT, hormone replacement therapy. What hormones are you actually talking about? Or MRT, menopause replacement therapy. We're doing this in the context of menopause. They're moving towards talking about PET therapy, talking about progesterone, estrogen, and testosterone, and trying to be really deliberate and the language we're using so that we're not lumping all hormones together, because all hormones don't behave the same. We've got to start being exceptionally clear about what we're talking about, because the risk is different. And that's where a lot of this fear has come from, by talking about hormone replacement therapy that was given 25 years ago. I mean, really, Premarin was developed in the 60s, right? We've moved on from the 60s. Well, in some ways we have, not nearly enough in a lot of others, right? But that's a conversation for another day. So the conclusion of this study was that they emphasize the safety advantage of transdermal estradiol combined with oral micronized progesterone, and support evidence-based recommendations for using these hormones, especially in women at high risk of blood clotting. And again, I've got this reference for you, and I will include them all in the show notes. So if we say, okay, so modern formulations don't seem to increase blood clotting risk, and we're thinking about blood clotting in terms of venous thromboembolism, stroke, heart attack, right? What about the WHI? When they went back and looked at follow-up data from the WHI, they found that coronary heart disease adverse outcomes, including non-fatal heart attacks and coronary heart disease death, did not differ between different age groups, right? So a lot of this fear was on, oh my God, we're going to kill people with heart attack and stroke. They didn't find that, even when they looked at different age groups. So in the conjugated equine estrogen plus the medroxyprogesterone acetate group, or the conjugated equine estrogen group alone, when compared with placebo, there was no difference in coronary heart disease in the 60 to 69-year-old group compared with placebo, or the 70 to 79-year-old group compared to placebo. Where they saw the difference was that there was a statistically significant increase in coronary heart disease in the women who were on CEE plus MPA when it was initiated 20 plus years after menopause. And as we'll go down and look at later, the absolute rate of that increase was still pretty small. So we've talked about this already. The type of hormone therapy matters. Oral versus transdermal estrogen. We're typically always using transdermal estrogen at this point. There's lower blood clotting risk. Why would we choose to use a medicine that had higher risk? The type of estrogen, using bioidentical estradiol versus conjugated equine estrogen, that's what's different. The other difference between what we're using now and the WHI is the type of progesterone versus progestogens, right? So progesterone is what your ovaries are making when you ovulate, and your little corpus luteum makes progesterone. That's a bioidentical hormone. It exists in your body, versus a progestogen like medroxyprogesterone acetate. This never existed in nature. This is a progesterone analog, but is not actually progesterone. And so when we look at the risk of coronary heart disease that was seen in the Women's Health Initiative with conjugated equine estrogen and medroxyprogesterone acetate, what was it? Okay, it was between 8 and 26 incidents of pulmonary embolus, stroke, etc., per 10,000 women per year. So let that number sit with you for a minute. 8 to 26 incidents, a bad coronary event per 10,000 women per year, compared on the women who are on CEE plus MPA versus placebo. Not a huge number, but this is what everybody has got their panties in a wad about and is really freaking out about. So when we compare the risk of 1 in 2 women will have an osteoporotic fracture, right? When we have an osteoporotic fracture, the chances of dying after you break your hip in the United States are 30% in the next year. And the vast majority of people who survive a hip fracture never return their normal level of functioning. So we really need to take a step back, take a big deep breath, and think about whole person health rather than really focusing on these esoteric risks. Okay, so we've talked a lot about blood clotting risk and cardiovascular risk. Let's move on a little bit to dementia risk. And I think this is an area where we're still learning. The WIM study, so the WHI memory study, found a twofold increased risk of probable dementia in women over 65 taking CEE plus MPA compared with those assigned a placebo. Okay, that sounds really scary, right? And that's what's written in that package insert. If you get any estrogen, if you get a transdermal estradiol patch, which wasn't studied in that study, that's what's going to say on the risk. And then you're going to go home and think your doctor's crazy and they're trying to kill you, right? So we've got mislabeling from the FDA here also. So if we look at the absolute numbers of that risk equated to 23 cases per 10,000 women per year. Okay, again, this is a JAMA study. The author is Shoemaker. It was published in 2003. I've got the reference and the hyperlink to the article for you and the references if you want to go back and check me. What about breast cancer risk? I think this is an area where people get really hung up. Again, just like cardiovascular risk, as we age, our risk for getting breast cancer goes up. Okay. So that 1 in 8 women in the United States will get breast cancer is if you live to be 80 years old. Okay. And I don't in any way mean to be insensitive or unkind if you are a breast cancer survivor. We are not trying to minimize your experience of this disease. I think that the breast cancer risk has been overstated. And again, we want to have a personalized framework to think about risk versus benefits in women versus responding emotionally from a place of fear. So if you look at the E3N trial, which is pretty old now, I think it was published in Postgraduate Medicine in 2010. Again, comparing the type of hormone we were using and on breast cancer risk, just like it's different with heart disease and blood clotting risk, it's different with breast cancer risk. So when we looked at using transdermal estradiol and oral micronized progesterone, so the type of progestogen really seems to matter for breast cancer risk, using oral micronized progesterone seems to be much safer than using a synthetic progestogen. We can never guarantee a patient there is no breast cancer risk. We are dumping poison, endocrine disruptors, forever chemicals in our water supply, in our environment. A lot of women are using a lot of endocrine disruptors on their physical person, fragrances, hair products, cosmetic products, nail polish, all of these things, hair dye. And so those all convey risk above and beyond hormone replacement therapy. So we're living, unfortunately, in a toxic soup that is unfortunately getting much worse. But when we're thinking about the added risk of hormone replacement therapy, if we're using bioidentical hormones, there's significant research that shows that the risk is minimal compared to controls and may not be at all increased risk with controls. So we talked a little bit about why kind of doctors have been taught to be afraid. And I think the last thing I'd like to kind of close with is what about mortality, right? Like, and did you die, right? And so if we're thinking about what did we learn from the WHI, understanding that we don't have a WHI study on the type of hormones we take now. We don't have a large following women for 20 plus years on transdermal estradiol and oral micronized progesterone. We need one. We deserve one. We don't have one. But if we're looking at the WHI and we're looking at all cause and cause specific mortality, what do we see? What are the results of this study? This is a pooled cohort, and they said among postmenopausal women, hormone therapy with CEE plus MPA for a median of 5.6 years, or with CEE alone for a median of 7.2 years, was not associated with a risk of all cause cardiovascular or cancer mortality during a cumulative follow-up of 18 years. So at the end of the day, did you die? No, you didn't. So I think that's really important to emphasize. I just wanted to highlight a paper. Unfortunately, this paper isn't open source. So that means that you have to pay or have a library that will let you get it. There's a paper by Susan Davis. It was published in Lancet Diabetes and Endocrinology in January of this year. And I'll give you a link to it in the show notes. I can't give you a link to the paper because it's behind a paywall, but it's called, Is It Time to Revisit Recommendations for Initiation of Hormone Menopausal Therapy? And I'd really encourage this it's a short paper. I've got it right in front of me. How many pages is it? Not that long. Less than 10 pages, maybe 5. It's short paper. And so if you can get this or give the citation to your healthcare provider, if you're getting a ton of pushback, I think this would be a great paper to bring to your healthcare team. And then like I've said, I've also made links to all the open source papers that are available and not behind a paywall. And they're all on a Google document for you. So if you want to walk onto your healthcare provider and be like, look, I think it's time for us to rethink this, you can walk in there supported with some data. The last thing I want to close with is just to be really clear. There are no age contraindications to vaginal hormones. And I don't think we can emphasize this enough. So the use of vaginal estradiol or vaginal DHEA decreases the incidence of urinary tract infections by half. Urinary tract infections in seniors often doesn't present like it did when we were 20, right? So maybe you remember getting a UTI in college and it felt like you were peeing razor blades and you knew that you had a UTI. It was super uncomfortable. Not the same if you're 70 years old. You may experience as UTI as maybe vague pelvic cramping and mental status changes and dizziness. UTIs can lead to falls. We've talked about the really significant risk of falling and breaking a hip. UTIs can also lead to sepsis and hospitalization, which can then lead to infections that we get from being in a hospital and being around superbugs. So there's no real excuse for not taking vaginal hormones. Even if you're a cancer survivor, it's completely safe to take vaginal hormones. As we age, we need to decrease the chances of having a urinary tract infection. And in my conversations with women, I also think it's important to emphasize that this isn't about sexual activity. Okay. So I think a lot of us as clinicians were taught, does it hurt to have sex? That's when we use vaginal hormones. No, ma'am. We use vaginal hormones to prevent urinary tract infections above and beyond if we need vaginal elasticity, moisture, improvement in sexual function. So some women are happily not sexually active in 70 plus. Many women are. Awesome. Go them, right? But what I want to say is that if you have a patient or if you're a patient and you're not sexually active, don't think that you don't need vaginal hormones. Your risk for getting a UTI and having a significant consequence of having a UTI goes up as you age. And so it's just super important to be on them. There's also no age contraindications to using testosterone. Testosterone, we know, is not FDA approved for women, but may help with bone health, may help with mood, may help with sleep, probably does help with libido, may help with muscle maintenance, particularly if we're eating adequate protein and doing resistance activity. There's no age restrictions to oral micronized progesterone. So I hope this leaves you with a framework to personalize therapy for considering starting hormone replacement therapy after the age of 60. And feel free to let me know if you've got questions. If this episode is helpful for you, please share it with a friend or a loved one. And again, there's references in the show notes. And so hopefully this can serve as some support to help you have a more productive conversation with your healthcare team. Let's make the second half of our lives the best half of our lives together. Thanks for listening to Menopause Rescue. We hope you've enjoyed this podcast and it helps you create some time and space to make this the best half of your life. If you've enjoyed this content, please leave us a 5-star rating and review. This helps other listeners find this resource and rescue and restore their health. If you enjoyed this topic and want to learn more, check out our resource guide for this episode. If today's podcast resonated with you and you want to take a deeper dive, check out my educational resources. We offer basic membership, which is an archive of over 100 videos on menopausal topics ranging from bone health to libido. We add to this archive every month, so the resource becomes richer and richer over time. If you're looking for a menopause expert and live in North Carolina, take our free online class and see if we're a match for your needs. It's called Are We a Good Fit? And is a quick and easy way to learn more about our practice and what it has to offer. Hey, this is Dr. Watson. This is just a friendly reminder that this podcast is for general information purposes only and does not constitute the practice of medicine. No doctor-patient relationship is formed, and any information you get from this podcast is considered educational only. You should make medical decisions with your healthcare provider. The content of this podcast is not intended to be a substitute for professional medical advice. Listeners should not disregard or delay in obtaining medical advice for any medical condition, and they should seek assistance from their healthcare professionals.